Hello everyone. In this video, we will talk about the drugs used in rheumatoid arthritis, and like all pharma videos, the video notes of this lecture will be available in the app for free download. So rheumatoid arthritis is a chronic inflammatory disorder. Basically, it is of autoimmune origin. So there is activation of the immune system against our own proteins and cells, and this leads to a chronic inflammatory disorders. And it is a systemic disease, that is, it affects the joints and some other tissues as well. And this disease is basically non-suppurative, that is, there is no pus formation. It is proliferative, that is, there is a proliferation of the synovial membrane, and inflammatory because of the involvement of the immune system. So this is the characteristic of this disease, and we'll just see in short the schematic diagram of joints so as to understand it little bit better. So in this diagram, we see two bones which are opposing each other, forming a joint. And here this is the articular cartilage. And here we see this green one is the synovial membrane. And by the lining of this synovial membrane, there is some space formed within the joint. This is the joint cavity or synovial cavity where synovial fluid is present. And it has contents like a hyaluron, which basically provide lubrication. And in this synovial membrane, we have two different types of cells, that is type A synoviocytes, which are the macrophages, and type B synoviocytes, which are the fibroblasts. And it is the proliferation of these fibroblasts and also the secretions from these fibroblasts which ultimately lead to damage of this joint. So what happens, that synovial membrane proliferates, that is the fibroblast starts proliferating, and here we see that proliferated area. With this, there is destruction of the articular cartilage because this fibroblast produce certain enzymes which cause destruction of the articular cartilage, and also there are bony erosions with osteoclast activation. So in detail little bit we will see. So this is the pathogenesis. Main cell involved is helper T cell, CD4 plus T cell, which is again a synovial CD4 plus T cell. Now when an antigen presenting cell presents an antigen similar to the antigens which are present in the joint, so this antigen presenting cell is presenting the antigen to this helper T cell, and there is also co-stimulation. See, this is basic physiology, that whenever antigen is presented, apart from this interaction between the T cell receptor and the MHC molecule over which the antigen is present, there is also interaction with some other proteins. This is known as co-stimulation, that is the second signal which is required for the activation of this CD4 plus T cell, helper T cell. Now once this happens, these T cells multiply and differentiate into different types. So we have T helper cell type 1, okay, Th1 and Th17 cell. Th1 cells secrete interferon gamma. This interferon gamma acts on the macrophages. We have seen in the synovial membrane there are macrophages, and also on the synovial fibroblasts. So both cells it is acting. Macrophages start releasing TNF-alpha and interleukin-1, and many other interleukins are released. Then this TNF-alpha, interleukin-1 and also interferon gamma, which act on the synovial fibroblast cell, because of that there is release of enzymes by this synovial fibroblast cells, and these enzymes are matrix metalloproteinases. So there are proteases which are released which destroy the cartilage, and also they release certain interleukins, that is interleukin-1, interleukin-6 and TNF-alpha. So you see this TNF-alpha, this is very important in the pathogenesis of this rheumatoid arthritis, and obviously there is involvement of other interleukins. Why I am talking about here? Because we will see later that there are drugs which are acting at these multiple levels, like TNF-alpha inhibitors are there, IL-1 antagonists are there, right? Then we have the other type of T helper cell, that is Th17, which releases interleukin 17, and there is recruitment of the neutrophils and monocytes, and there is increase in the inflammation. Then this T helper cell also has this rank L. So this is the ligand for a receptor which is present on osteoclast, that is the rank. So this is a receptor, okay. So this is a T helper cell which was presented. Now, this rank ligand interacts with the rank present on the osteoclast. This leads to maturation of the osteoclast, which leads to bone lysis. So, I told you there is bony erosions, isn't it? So, that is because of the maturation of the osteoclast. Also, this T helper cell interacts with the B cell by means of CD40 receptor on the B cell, CD40 ligand on the T cell, and this leads to maturation of the B cells and release of certain antibodies, that is rheumatoid factor and anti-CCP antibodies. Now, these anti-CCP antibodies are directed against proteins which are present in the joints, for example, vimentin, collagen, and some other proteins as well. Now, remember here that all these aspects of pathophysiology which we saw, we will see that drugs act at multiple levels. And this TNF-alpha is very important for pathogenesis of rheumatoid arthritis because it is involved in various aspects. For example, it causes fibroblast stimulation, which increase matrix metalloprotease secretion, RANKL expression also, which is important for osteoclast maturation. And this is important for the basic characteristics of rheumatoid arthritis, that is synovial membrane proliferation leading to formation of pannus. Pannus is basically the synovial membrane proliferation with the connective tissue and the blood vessel growth, that is angiogenesis. Okay, destruction of cartilage, articular cartilage is destroyed because of this increased MMP, and bony erosions also occur because of osteoclast activation. Then it also leads to pain pathway sensitization causing pain and osteoclastogenesis, that is bone lysis, that we have already discussed. So what are the drugs which are used in rheumatoid arthritis? Well, once we have understood the pathophysiology, it is easy to understand the drugs. So one is the drugs which are used for decreasing the pain and inflammation, that is the NSAIDs. Then we have disease modifying antirheumatic drugs, that is DMARDs, and finally we have corticosteroids. This disease modifying antirheumatic drugs are the drugs which interfere with the pathogenesis. See, NSAIDs, they will decrease the pain and inflammation, but they will not act on the root cause of the disease. On the other hand, DMARDs are required because they act on the root cause of the disease. So in DMARDs, we have the non-biologicals, that is the synthetic drugs, and then we have the biologicals. Biologicals are the ones which act on the cytokines and its actions. So amongst the non-biologicals, we have the immunosuppressants, that is the methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, azathioprine, and there are certain other drugs which are not used now, that is penicillamine and gold salt. We have JAK kinase inhibitors as well, that we will see the mechanism how they act, right? Then we have the biologicals. In biologicals, we have main TNF-alpha inhibitors, and then there are others, that is the co-stimulation inhibitors. We have seen, right, for activation of helper T cells, there is co-stimulation required. So co-stimulation inhibitors are there. Interleukin-1 receptor antagonist, interleukin-6 receptor antagonist. So that will interfere with the action of these interleukins. And then we have B cell depleters, and we have seen that how B cells are releasing certain antibodies. So once you know the pathophysiology, now it is easy to understand these drugs. So first is NSAIDs. As I told, they basically offer the symptomatic relief. Now before they were considered the first line drug, especially for mild rheumatoid arthritis, but now it is considered that with NSAIDs we should add DMARDs as well. Okay, so these NSAIDs only provide symptomatic relief and are adjunctive agents, and they do not affect disease process. They have analgesic plus anti-inflammatory action. And among these NSAIDs, the ones which are used for rheumatoid arthritis include naproxen, diclofenac, piroxicam. This we have already seen that diclofenac is one of the most common drug which is used for its anti-inflammatory action, and naproxen and piroxicam are used because they have long duration of action. Naproxen can be given twice daily and piroxicam can be given even OD. However, piroxicam we have seen in our video on NSAIDs that it has a higher toxicity profile, so it is not the first drug which is chosen. Right. So yes, NSAIDs have to be given, but minimize chronic use because side effects we know that include the peptic ulcer disease, gastritis and analgesic nephropathy. On chronic use, there are high chances of these side effects to occur. Then moving on to next drugs, that is the non-biologicals or the synthetic DMARDs, conventional synthetic DMARDs, and we have the newer synthetic DMARDs. Conventional synthetic include 5 main drugs which we will talk about, that is methotrexate, azathioprine, leflunomide, sulfasalazine and hydroxychloroquine, and then we have the newer drug, that is the JAK kinase inhibitors, that is the cytokine receptor blockers. Basically these are not receptor blockers, these are signaling blockers. Okay, signaling blockers. Now methotrexate, leflunomide, sulfasalazine and hydroxychloroquine are the ones which are commonly used. Azathioprine, though it is given in KDT, I couldn't see it as the priority drug in other books. So for us, priority drugs include methotrexate, leflunomide, sulfasalazine and hydroxychloroquine. Now amongst this, methotrexate is the first choice of the drug. Okay, so in DMARDs, it is the first drug which is added. If methotrexate contraindications are there, then in spite of methotrexate, we can give leflunomide. Fine. Then suppose the methotrexate is added, but still the patient is not responding to the methotrexate, then later on sulfasalazine and hydroxychloroquine need to be added. So this is known as triple therapy. Triple therapy. Okay, so first choice is methotrexate. But how do these drugs act? Well, methotrexate is a dihydrofolate reductase enzyme inhibitor. Now this enzyme, dihydrofolate reductase, it converts dihydrofolic acid to tetrahydrofolic acid, which is required for pyrimidine and purine synthesis. Now in pathophysiology, we have seen that there are so many different types of cells involved, and for their proliferation, DNA synthesis is needed. And for DNA synthesis, we need pyrimidine and purine synthesis. So by inhibiting this enzyme, basically we are interfering with pyrimidine and purine synthesis. Now that is the classical mechanism of action of methotrexate. However, now it is known that in rheumatoid arthritis, basically its action is because it causes release of adenosine from cells. So whatever adenosine has accumulated within the cells, it causes its release from the cell, and because of this, it is acting in rheumatoid arthritis. And in fact, because of its action for inhibiting this dihydrofolate reductase, folic acid is given as a co-therapy, otherwise there will be side effects of inhibition of this DHFR, right? Second, we have leflunomide. Leflunomide inhibits another enzyme, that is dihydroorotate dehydrogenase. This enzyme is required for pyrimidine synthesis. Azathioprine, on the other hand, inhibits the purine synthesis. Fine. So methotrexate, leflunomide and azathioprine, we can say that they are inhibiting the DNA synthesis, and methotrexate also releases adenosine from cells. Now, I told you that methotrexate is a first choice drug, and if methotrexate is contraindicated, then leflunomide is used. However, if we see the side effect profile, it is almost similar in methotrexate and leflunomide. Both are hepatotoxic, both cause bone marrow suppression, and both predispose to infection. Methotrexate also causes interstitial pneumonitis, and this interstitial pneumonitis, actually interstitial lung disease, can occur in rheumatoid arthritis, because I have told you that apart from the joint, other tissues can also be affected in rheumatoid arthritis. So methotrexate, if given in that condition, see its side effect is itself interstitial pneumonitis, then it becomes very difficult. So we have to choose some other drug for that. Right? And both methotrexate and leflunomide are contraindicated in pregnancy and lactation. And methotrexate, before starting that drug, we need to do liver function test. Okay, because we have to make sure that the person is eligible for this therapy. If LFT is not normal, then we don't start with methotrexate. It is also contraindicated in case of active infection and leukopenia, because I told you that it increases the chances of infection. Basically, these drugs are interfering with immune function. So we will see that almost all the drugs increase the chances of infection, right? So that was methotrexate, leflunomide and azathioprine. Then we have other drugs, sulfasalazine. Mechanism of action is not known. Hydroxychloroquine, also mechanism of action is not known, but both of these drugs are second line drugs, and they are added when the response to methotrexate is not enough. So we start with triple therapy. But remember, hydroxychloroquine, one side effect is retinal damage and corneal opacity. So when you are treating the patient chronically and he starts complaining of blurring of vision, then you have to understand that it may be because of hydroxychloroquine therapy. So in summary, these non-biologicals Methotrexate, azathioprine, leflunomide interfere with DNA synthesis and they are interfering with the proliferation of our T cells and also B cells, right? Then moving on to the second, that is the JAK kinase inhibitors. These can be added when there is inadequate response to methotrexate or methotrexate is contraindicated. So what they do is, actually these interleukins which we are seeing, they bind with the receptors present on the cells. So whatever receptors are there, interleukin receptors, they generally act by this JAK kinase signaling. So there is a JAK STAT receptor, you might be knowing from your physiology. If that signaling is interfered, the interleukin action will be interfered. So one example of this drug is tofacitinib. Okay, it interferes with JAK kinase signaling. And what can be the side effect of this drug? See, again, it is interfering with immune function. So it can predispose the person to infection. Also, one other important side effect is that it causes dyslipidemia. There is increase in the cholesterol levels and also it increases the LFT enzymes. Okay, so this dyslipidemia is asked in MCQs as well. JAK kinase inhibitor causes dyslipidemia. Moving on to the other drugs, that is TNF-alpha inhibitors. So now we are moving on to the biologicals. We have seen that how this TNF-alpha is very important in the pathophysiology. So these TNF-alpha inhibitors, some examples include etanercept, infliximab, adalimumab, then golimumab. So these are monoclonal antibodies. Etanercept is a fusion protein basically of TNF-alpha receptor, and this TNF-alpha receptor combines with this TNF-alpha, preventing the binding of TNF-alpha to the receptors which are present on the cells. Okay, so these TNF-alpha receptors decrease the macrophage function and also T cell function, but because again they are interfering with the immunity, so there are increased chances of opportunistic infections, especially the granulomatous infections. See, there are certain bacteria which are walled off by our macrophages. So our macrophages basically convert into epithelioid cells and they wall off the bacteria. Now because TNF-alpha inhibitors are interfering with the action of the macrophages, this walling off is broken down and there will be high chances of the latent infection which is present or new infection also. So one very important infection in this case is tuberculosis. So if a patient is having latent tuberculosis, then it will become active in case we are starting with TNF-alpha inhibitors. So whenever these drugs are started, we have to screen for latent tuberculosis. So when are these TNF-alpha inhibitors used? Well, they are used in combination with methotrexate if response to methotrexate is not appropriate, and also they are combined with methotrexate in case of rapidly progressing cases, right? Moving on to other biologicals, we have 4 drugs in that. One is a drug which prevents co-stimulation. So that is abatacept. So here we have seen before that this is the T cell receptor and this is CD28 and this is like CD80. Now if we add one antibody that is combined with another protein, that is CTLA4. Now CTLA4 is a receptor which will combine with this CD80. So it will prevent the interaction of CD80 with CD28, which is important for co-stimulation. So that will prevent the activation of the helper T cell. That is one. Second is rituximab. Rituximab targets CD20 receptor on the B cells and this depletes B cells, so there is no production of the antibodies. Third is anakinra, which is interleukin 1 receptor antagonist. It is rarely used now for rheumatoid arthritis. It was not found to be very effective. And fourth one is interleukin 6 receptor antagonist. So it binds with the interleukin 6 receptor, preventing the action of interleukin 6, which we have seen. So the drugs in this category include tocilizumab and sarilumab. Again, these are used in combination with methotrexate if there is a decreased response to methotrexate. And what will be the side effects? Yes, there will be increased risk of infection with all these drugs. And this interleukin 6 receptor antagonist, just like the JAK kinase inhibitors, it also causes increased LFT and dyslipidemia. Okay. So you see, all are increasing the chances of infection. JAK kinase inhibitors and interleukin 6 receptor antagonists, they are also increasing LFT enzymes and are causing dyslipidemia. So that were the other biological agents, right? Moving on to the last drug, that is the corticosteroids. Now these corticosteroids are not recommended for chronic use. However, there are certain indications for which they can be used. One, severe systemic manifestations. So in that case, high doses are given for short periods for controlling the disease. Second, intra-articular injections. So if a few joints are involved but there are severe symptoms, so directly into those joints, triamcinolone injections can be given. Then in low to moderate doses, corticosteroids can be given before the disease modifying antirheumatic drugs take effect. Actually, these DMARD drugs take approximately 6 to 12 weeks to act. So before that, you have to control the disease. So during that time, corticosteroids can be given. Then they can also be given for short term for acute disease flares. Okay, so they are given for severe systemic manifestations, again short periods, only high doses, and for acute disease flares which happen in between that also short term corticosteroids can be given. Then sometimes their chronic use is unavoidable. If there is no response to DMARDs, then sometimes they can be added for chronic use with DMARDs, but they are best avoided, remember, because when you use it chronically, then over time its side effect is osteoporosis. Okay, so it is best avoided. Fine. So that was about the drugs used in rheumatoid arthritis. I hope you understood the concept. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.